urinary incontinence, overactive bladder, and urge incontinence. For those with overactive bladder, or OAB, the overriding symptom is one of intense urinary urgency, that is, an overwhelming need or desire to pass urine, which is difficult to defer. This is a clinical diagnosis that does not require invasive testing. This constellation of symptoms, that is urgency, frequency, and nocturia, without urinary leakage may be referred to as dry overactive bladder. Overactive bladder with urinary leakage is the result of an involuntary bladder, that is, detrusor contraction, and may be called wet overactive bladder. One can have overactive bladder without leakage. Lower urinary tract symptoms, or LUTS, is terminology for the constellation of symptoms that most commonly include urinary urgency, frequency, and nocturia. Prevalence rates for overactive bladder in the United States is about 16% for both men and women. Overactive bladder symptoms are prevalent in both men and women, particularly as they age. The underlying pathology for overactive bladder and urgency incontinence is not clearly understood. Mixed incontinence occurs when the individual has stress urinary incontinence and overactive bladder with incontinence symptoms to include urge incontinence. Symptoms of overactive bladder increase with age. Changes within the bladder as one ages, such as increased collagen content, changes in the sensitivity of sensory receptors, reduction in detrusor M3 receptors, changes to the aging brain that prevent suppression of the sensation of urgency, hypertension, and hypercholesteremia help explain this symptom increase. Obesity is a strong factor for overactive bladder, but not as much as a contributor as it would be for stress incontinence. There are foods and drinks that also seem to be associated with overactive bladder symptoms, and this varies from one person to the next. Some of the foods implicated include aspartame, alcohol, caffeine, coffee, including decaffeinated coffee, highly spiced foods, wine, citrus, chocolate, bath preparations, and a variety of others. These are all collectively known as environmental irritants, as they can locally affect the environment of the bladder and cause irritative symptoms of urgency and frequency. Smoking, low physical exercise, and high carbohydrate diets, along with obesity and diabetes, have also been associated with an increased risk for overactive bladder. Bladder outlet obstruction that is something that is blocking the outlet of the bladder can also contribute to overactive bladder symptoms. There has been an association shown between bladder outlet obstruction and increased detrusor contractions, also called detrusor overactivity. Problems that result in bladder outflow obstruction include an enlarged prostate or a surgical treatment for stress urinary incontinence that can result in outflow obstruction. Those with childhood continence issues such as nocturnal enuresis are also at an increase for overactive bladder. In the pregnant female, the bladder may be unable to expand to its full extent due to the pregnant uterus, and the overactive bladder symptoms will increase as the pregnancy progresses. Less common causes for overactive bladder include limitofunctional capacity that can result from tumors or stones, as the amount of space for holding urine would be diminished, medications such as methotrexate and diuretics, and neurologic lesions that affect the cerebral cortex, which causes neurogenic detrusor overactivity or damage to the pons, which is in the area of the brain that provides social continence. These lesions can include multiple sclerosis and cardiovascular accident. Urgency is defined as the inability to delay voiding until a socially acceptable time. The feeling is one of, I have to go now. The urge cannot be deferred, so the individual rushes to the bathroom. This feeling is often accompanied by incontinence. People become very afraid of urine leakage. They may go to the bathroom at very frequent intervals, kind of just in case, in order to prevent any accident. The amount of urine that is voided tends to be small, but the full bladder volume is emptied. Frequency has no specific definition, although diurnal frequency is defined as 8 times in 24 hours. In order to determine an individual's frequency, a bladder diary is invaluable in providing that information. Nocturia is defined as waking up at night 1 or more times to void. It occurs when the person is woken up by the need to void, rather than being awake and going to the bathroom to void. Once a night seems to be pretty much acceptable for most people, but more than that becomes bothersome. Some individuals also complain of urinary incontinence during intercourse, which is, as you can imagine, embarrassing and bothersome. Other symptoms may include toilet mapping, that is, making a conscious effort to know where all the bathrooms are located in the area the person visits. For example, the person who knows where all the bathrooms are at the mall where they like to shop. There's also a door key or latch key incontinence, in which the person is incontinent as they are putting the key in the door to open it. Exacerbating factors may include cold weather, running water, and psychological stress. A patient history is key in diagnosing overactive bladder or urge incontinence. There is not a specific diagnostic test that is specific for OAB. In general, a history is obtained including information on the individual's quality of life, or how the problem is affecting his or her life. Specific areas that are important to query the individual about include daytime and nighttime frequency, of which a bladder diary is key for this. Examples of bladder diaries or bladder charts are in the assessment lesson. For urgency, how long do they hold on? Any symptoms of stress incontinence, that is leakage with the laughing, sneezing, coughing, heavy lifting, products used for skincare, and strategies for dealing with the situation. Cognitive status and mobility issues are also important to find out about. If one has to be able to locate toilet facilities, undo clothing in the right order in order to remain continent. Any factor that limits cognitive status and social mobility issues will need to be addressed. The physical includes an abdominal assessment evaluating for evidence of prior surgeries or distended bladder. The perineal skin is examined for evidence of incontinent-associated dermatitis, as well as evidence of organ prolapse and the quality of vaginal tissue. Pelvic floor muscle strength is determined as the ability of the person to perform a contraction of the pelvic muscles. A rectal examination is done if constipation or fecal impaction is suspected. The fecal lift in the rectum can push forward, causing decreased ability of the bladder to contract properly, which results in a sense of frequency. Baseline laboratory tests include a urine dipstick if there are symptoms of UTI, diabetes, or hematuria. A post-void residual is done if there is any concern about emptying of the bladder. Urodynamic testing is seldom needed unless the person presents with a complex history or those who have neurologic lesions. Urge incontinence results when someone with overactive bladder is incontinent. In the past, urge incontinence was also known as unstable bladder, detrusor instability, or bladder contraction without the owner's permission in an individual with otherwise intact sensation. Detrusor hyperactivity with impaired contractility, or detrusor hyperreflexia, which is overactivity associated with neurologic lesion or a condition such as with a cerebral vascular accident. If the overactive bladder is a result of obstruction, the obstruction needs to be treated. Many times this is a result of an enlarged prostate, and medications that reduce the size of the prostate, which include the 5-alpha reductase inhibitors such as finasteride and dutasteroid, may be prescribed. Surgery or prostatectomy may be needed if that doesn't work. If an infection is present, of course it needs to be managed. When an individual begins to have symptoms of frequency or urinary leakage, the first tendency is to decrease fluid intake. Now, this has the side effect of leading to a more concentrated urine and can actually worsen the situation. Increasing fluids, if not medically contraindicated, to 30 milliliters per kilogram in a 24-hour period or 1/2 ounce per pound per day is recommended. This averages out to be about 2 liters per day. Individuals need to be aware of which foods or fluids are environmental irritants, that is, irritating the environment of the bladder. And culprits, again, can include aspartame, coffee in both caffeinated and decaf versions, chocolate, wine, citrus drinks and fruits, tomato products, and highly spiced foods. Caffeinated products have been implicated in particular as a cause of overactive bladder. There may be other foods or beverages that can affect a particular individual. A bladder diary with a food chart can be helpful in pinpointing these foods that are bothersome for a particular individual. People who do not have to totally shy away from a food or fluid that are bladder irritants, but need to decrease the amounts. If done on a gradual basis, for example, decrease by 1 cup of coffee per day or per week can make it easier. With this being said, there is a paucity of good research to substantiate this information. Constipation management is also important. Impacted stool needs to be removed and a bowel management regime needs to be initiated. This usually includes increasing fluids, exercising, and increasing the bulk in the diet. A recipe is often used which varies from one person or institution to another, but is something similar to a cup of unprocessed wheat bran, a cup of applesauce, and a 1/2 cup of prune juice, and refrigerate. Take 2 tablespoons every day with a glass of water or juice. Within a week, bowel movements should become soft and regular. Increase by 1 to 2 tablespoons per week, up to 8 tablespoons as needed. Appropriate water intake is key to prevent this recipe from actually increasing constipation due to the bran pulling in water from the bowel lumen. The technique for squeezing the pelvic floor muscles is taught and learned with the use of biofeedback if the person is having a great deal of difficulty in identifying and correctly using the muscles of the pelvic floor. These muscles are then used in a technique called the knack, and is used along with urge inhibition techniques and bladder retraining, which will be spoken about in more depth. Urge control strategies, also called urge inhibition or suppression strategies, can be used with anyone, but are specifically used for those individuals with urgency. These strategies can help them to buy time, if you will, in order to calmly get to the bathroom without incident. These techniques are used by themselves or in conjunction with bladder training and toileting programs. The steps as outlined on this slide include deep breathing, 5 quick Kegels, also known as the knack, and distraction techniques. Bladder retraining includes voiding per schedule, then gradually increasing the schedule to a more normal voiding routine. Pelvic floor muscle rehabilitation results in strengthened external sphincters and at the same time relaxes the detrusor so it is able to hold the urine within it. When one has the urge to void, the knack technique is used to give time for the bladder to relax, and this provides time for the person to head to the bathroom without haste. Urge control or urge suppression techniques are used to override the urge sensation, delaying voiding until a convenient time for the patient. It includes techniques to get the individual's mind off of the bladder, allowing the bladder time to relax and give the person time to get to the bathroom without leakage. In this process, it is important for the individual to learn that it is the brain over bladder and not bladder over brain. 30 seconds of concentration on something else is effective in calming the bladder. It takes time and energy, but results in good payoff for the person in terms of providing some control. When the urge to void hits, the person should stop what he or she is doing and have a moment of stillness. Then 5 quick pelvic floor muscle contractions known as the knack helps by relaxing the detrusor muscle as the sphincter is contracted. Remember, there is a concomitant relaxation of the bladder muscle when the sphincter is contracted, and this helps to settle the muscle, if you will, decreasing the urge to go. One may also want to sit on a hard surface, perhaps a rolled towel, as this does help individuals regain control. The patient uses imagery, also known as self-talk, to get their brain off the bladder by not focusing on bladder signals, which gives time for the urge to subside. Thinking of planning the next day's activities, what to do with grandchildren, or reviewing the book chapter that one just read are examples of things that can be thought about. In other words, providing that image and take the brain off the bladder. The person can also count backwards from 100 by 7s or 9s, as this is harder to do than other numbers. It does not matter what's being thought about, as long as the thinking is not on the bladder urge. Once the urge subsides, the individual can smoothly walk to the bathroom at their usual rate of speed. Bladder training is a method used to increase the actual time between voidings. It is used along with the urge suppression techniques that we just talked about. It does require extensive commitment from the patient and has been shown to reduce urgency and improve urge incontinence. Initially, an individual uses a bladder diary for about 3 days in order to determine bathroom frequency and fluid intake. When people have urgency, it is not uncommon for them to lose control as they reach the bathroom, or, has been described earlier, while putting the key in the door when they return home. As a result, people become afraid that they will again become incontinent, so they rush, which increases bladder sensitivity and tends to worsen the situation. By getting control over bladder function, people are able to relax, which relaxes the bladder, thus increasing capacity. In bladder training, once the bladder record is completed, the person is then asked to increase the time between bathroom trips. When the urge to go hits, they're asked to hold it for an extra minute or two using the knack and imagery techniques. Gradually over time, a more normal 3 to 4 hour voiding interval is obtained. It is slow work, it takes effort, it takes encouragement from healthcare team members, but has been shown to work, and most individuals find it is worth the effort. Prompted voiding is useful for persons who are able to recognize a full bladder and respond when prompted to void, but may have functional limitations that prohibit them from getting to the bathroom. The individual needs to be able to tell if they're wet or dry and make a judgment on the need to void. It is a useful technique for individuals with compromised mobility or mild to moderate degrees of cognitive impairment. The person is prompted to use the toilet and asked if they have to void, and then given a social reward when they are successfully toileted. This can include praise and verbal encouragement. For example, the caregiver may say, "Mary, you're dry, how wonderful." If the person is found to be wet, they are informed of this by the caregiver and taken to the bathroom in order to attempt to void, and then clean undergarments are applied after skin care is provided. A script at the beginning may be helpful for all caregivers to follow. A 3-day trial can be used to check efficacy of the prompted voiding for a particular individual. The trial is considered successful if there is at least a 20% reduction in incontinent episodes. Caregivers must be trained in the technique and at times need to be convinced that the effort is worth the results. This is an appropriate, albeit labor-intensive intervention for those with dementia who can successfully toilet 2/3 of the time or who achieve 20% reduction in incontinent episodes. Habit retraining requires identification of the individual's own voiding pattern. A bladder diary is obtained for baseline information. A schedule is then devised on the bladder diary. and the purpose is to toilet the individual prior to the usual incontinent times. Timed and scheduled voiding provides toileting assistance on a consistent schedule. There are no attempts to individualize the program or provide motivation. The individual is assisted to the bathroom on a fixed schedule, such as every 3 hours. The technique is most appropriate for the cognitively intact person with mobility issues and for those who would not benefit from one of the other methods meant to assist in restoration of continence. Remember also that sleep is important for good health, so nighttime the caregiver may choose to use some form of a containment garment as well as skin care. Physical exercise programs have been shown in a variety of settings to improve continence. A structured program such as walking done on a daily basis has been shown to be effective. These techniques are labor-intensive and require commitment on the part of the caregivers. In some cases, this can be a roadblock to implementation. Medications that may contribute to the continence difficulty also need to be adjusted, perhaps looking at the timing of diuretics, for example. Use of topical estrogen in the form of cream, vaginal rings, or pessaries is often used for postmenopausal women. Antimuscarinics such as darafenicin, fesoterodine, oxybutynin, and solifenacin, tolterodine, and trospium chloride act to block the activation of muscarinic receptors in the urothelium and detrusor, in essence relaxing the bladder. This reduces the sense of urgency and increases bladder capacity. Side effects contribute to the long-term follow-through in many patients, and they're off the medications within 12 months. These side effects include dry mouth and constipation. In the elderly, it's important to be careful as these medications can contribute to delirium. Oxybutynin in particular is not recommended for use in the elderly. Darafenicin, trospium, solifenacin, and tolterodine do not cross the blood-brain barrier and so have less central nervous system effects. These medications do have similar rates, though, of causing dry mouth and constipation. B agonist mirabegron works to relax the bladder muscle wall, allowing for decreasing contractions with an increase in storage ability of the detrusor. It works well in all ages with decreased rates of dry mouth. Its side effect profile does not cause the same issues as antimuscarinics, including the dry mouth and constipation issues, but it can result in new onset or worsening hypertension. Botulinum toxin A is injected under endoscopic guidance during a cystoscopy to multiple sites in the bladder muscle. The toxin acts to paralyze the detrusor, thus decreasing unwanted contractions. This results in increased bladder capacity, decreased intravesical pressure, and reduced incontinent episodes. Side effects of this therapy can include UTI, urinary retention, hematuria, dysuria, and constipation. Patients who are unable to void after the procedure will need to learn how to perform intermittent self-catheterization. The injections need to be repeated periodically. Neuromodulation, also known as electrical stim, uses electrical activity to alter the involuntary reflexes of the lower urinary tract, thus suppressing overactive bladder contractions, strengthens motor nerves supplying the pelvic floor, and blocks painful or irritative bladder symptoms, thus aiding the individual in decreasing incontinent episodes. Electrical stimulation can be provided transvaginally through sacral nerve stimulation and tibial nerve stimulation. Delivery for transvaginal electrical stimulation is delivered via vaginal or rectal probe that is attached to the electrical source box. The e-stim is generally provided in the outpatient setting about 2 to 3 times a week for about 15 to 30 minutes, depending on the protocol used. It can be used in a home situation as well, and is often guided by the physical therapist. Sacral nerve stimulation. An implantable electrode is placed into the nerve at S3 to provide it with stimulation. individuals are pre-screened with a percutaneous device to check for efficacy. In the screening phase, electrodes are placed percutaneously adjacent to the S3 dorsal roots. If there is more than 50% improvement within a 1 to 4 week trial period, a permanent lead implantation with pacemaker-like stimulator is placed under the skin at the buttocks. This can be seen in the photograph on the slide. Long-term results have been positive. Negative events include lead migration, pain at the stimulator or insertion site, infection, and transient electrical shock. Tibial nerve stimulation is used for those who have not responded to more conservative treatments. A non-blinded, multi-center trial with 100 patients indicate the same results as use of tolidaridyne without side effects. Needle electrodes are placed medially above the ankle for a week to 10 to 12 weeks, or the device is implanted in the same area. When all other treatments fail, consideration to the surgical procedure augmentation cystoplasty may be given. In this surgical procedure, done laparoscopically or open, a piece of small bowel is used to enlarge or augment the bladder, thus increasing bladder capacity. There are many complications, including urinary tract infection and perforation of the augmented bladder. It is common after this procedure for the individual to self-catheterize in order to keep the urine volume down. Those individuals with mixed incontinence present with complaints of urine leakage with activity, as well as symptoms of overactive bladder with urge incontinence, that is, urgency, frequency, and nocturia. Management then needs to address both complaints, usually treating the symptoms most disturbing to the patient first. Treatment would include pelvic floor muscle rehabilitation, weight loss, dietary modifications, that is, removal of bladder irritants such as coffee, caffeine, wine, and similar fluids, as well as other lifestyle modifications, urge inhibition strategies, medications, bladder training programs, and potentially surgery if symptoms are bothersome enough. This ends our lesson on overactive urge incontinence. Thank you for your attention.